50-year gentleman, resident of Delhi, presented with the chief complaints of non-healing ulcer for last 3 years in the right ankle. Patient
This is not ankle.
the posterior aspect of the right ankle, sir.
Heel है ये,
Heel.
above the heel.
It's here, no?
The
This is okay. You carry on.
Yes, sir. So the ulcer was painless to begin with, and has been and there is a gradual progressive increase in size and has become painful in the recent past. There is history of difficulty in walking also. There is history of trauma that patient gives, which the patient didn't give much attention to. Patient has been getting regular dressings done for the ulcer, but the ulcer is not healing. Patient is a non-alcohol consumer and non-tobacco consumer and takes a mixed Indian diet. Sir, on examination, patient was examined in a well-lit room after taking informed consent for videography as well as photography. His Karnofsky's performance status is 90 by 100. He is well hydrated and well nourished. He's vitally stable, and general physical examination also.
What's wrong with the performance status he has mentioned?
We can't assess the performance status accurately because the patient has difficulty walking in view of the
That is
ulcer.
one. Number two, 90 is very mild symptoms. A patient with such a lesion who is limping and has difficulty, it is around 80. 90 is very mild symptoms. 90 is almost like you. This is more than that. No?
Yes, sir.
Should be 80 Karnofsky. What else?
Yes, sir. So, on examination of the lower limbs, patient is lying in prone position, and both the limbs are extended, and there is no extension or flexion.
There is not the limb is not in the normal attitude. What is the attitude of the limb?
So it is-
सीधे रहिए बाबा जी,
So,
कोई बात
plantar
नहीं. आप
flexion.
सीधे हो जाइए. You can compare the two.
Yes, sir,
The
there
right,
is.
left lower limb is normal. The right lower limb, yes.
Yes, sir. So the right lower limb is in plantar flexion attitude, and so there is a scar present on the dorsum of the ankle.
So there is a bulge here. There is a visible deformity, and you can see there are changes in the
Arch.
callosities. You can see the callosity here, and the arch is completely neutralized. So you can see the arch is obliterated. Because the way the patient has been walking, and this must have followed the injury that he sustained, right? So there is a visible deformity. So initially, when you are describing the attitude, it has to be in a position that the patient normally sits in. You can't just put the patient in a prone position and then start describing the attitude, because that will be incorrect, no? आप करवट ले लीजिए बाबा जी आराम से.
An ulcer which is spheroid in shape with irregular margins.
Spheroid, how would it be?
Spheroid.
Ulcer cannot be spheroidal.
Spheroid. I meant
Circular.
Circular.
Spheroid is 3 dimensions, no?
Circular in shape with irregular margins. There are suture present on the right
That's
lateral
okay.
aspect.
What about the edges?
So edges are everted, sir, and there is fluff.
No, at places they are everted, and then at other places we don't know. Somebody has done something.
Yes, sir.
Maybe the suture itself indicates that somebody must have taken a biopsy. And
So on palpation, it is tender to touch. The induration extends beyond the margin, and the ulcer is infiltrating into the
what is the
underlying
base?
Achilles.
So what is forming the base?
The base is formed by the underlying Achilles tendon muscle, sir.
I think it is a calcaneum. I can feel the bone. So underlying bone
Bone.
and the tendon you are referring to is here.
Yes, sir.
That's a tendon. That's the tendoachilles. And this is calcaneum. So it's involving it's actually, is it fixed to calcaneum or it's free?
So it seems free from the calcaneum.
It is fixed
Okay.
to begin with. So I don't have any reason to suspect that the bone is free clinically. And that's the tendon you are referring to, which has nothing to do with it. You can see it more clearly here and compare the two sides. This is calcaneum.
The heel is broadened also.
Broadened, and there's a bit of widening here, you see that,
Widening.
है ना? And the movements at the अपने आप पैर चलाइए, हलू पंजा चलाइए. I would not bother him much with that. Always do the active movements first. This is what I am saying. ये वाला. It is not. It is just restricted, but it's not that it is completely gone. And eversion and inversion he has done. They are not at the ankle joint. They are
Subtalar.
beyond. They are at the.
Subtalar joint.
Don't do that mistake. The eversion and inversion is that.
Subtalar.
So only the dorsiflexion and plantar flexion is done at the ankle. And this looks like involving the bone. It's fixed to the bone. So I would consider it involved unless proven otherwise, right?
Yes, sir.
And how is that important for me? If I think it's a malignancy, then I think the bone is involved. Then if the bone is involved, that could be one of the reasons for not being able to save the limb of many a times. Although we can remove the bone and still achieve a clear margin, but that is one thing you need to observe. What's your diagnosis based on the rest of the examination? Neurovascular deficit.
Yes, sir.
So the repetition of examination of the limb should be just the same. Examine the normal side first,
Yes, sir.
the attitude, apparent lengthening or shortening, gait, any visible deformity, any sinuses, ulcers, non-healing ulcers, etc.
Wasting.
Any visible dilated veins or vessels that you can see, the way like varicose veins, etc. Any visible ulcer, skin changes, and then come to the motor part of it. Any obvious wasting of muscles, any joint related issues, restricted movements, regional lymph nodes, all the joints and the regional lymph nodes examination, that completes the limb as a whole. So these points are all to be covered, which you got. Most of it you covered, but try to keep it in a focused method so that there is no confusion in, you don't miss out. A neurovascular deficit, you would look by looking at the attitude again, which is similar to what you do in CNS. Higher functions, motor system, sensory system, cranial nerves, reflexes, deep and superficial. That's what you do in CNS, am I right?
Yes, sir.
So here, translate that into the limb, extrapolate it. The higher functions for a limb would be the attitude, the positional sense, gait. Then motor system would be power, tone. Power is graded, no? You have grade 1, grade 2, grade 3. And
Movements
motor
at all the
system.
joints.
Motor system, then sensory systems, which is the dermatomes. And how do you look for the dermatomes? Hands in the pockets. 2, 3, 4. So, and down laterally it will be L5, S1 you walk on, then S2 medially, S3 you sit on. This needs to be examined. Sensory goes first. All that needs to be described, and this looks like a malignant ulcer to you. Why do you think it is malignant?
So because it's fixed to the underlying bone and it's a chronic non-healing ulcer which was initially painless and then became painful.
Good. And
And so there are dilated veins present proximally.
So we have points in history, points in examination.
so points in history and points in examination, what are
Points in
those?
history, sir, it was initially painless. It is a non-healing ulcer of more than 6 weeks duration, and patient is also known smoker also. And there was a increase in size also, sir. And initially it was painless to begin with, and points in examination
History of trauma also.
and history of trauma also, sir. And
Why should that make it malignant?
So that
repeated
would go
micro-
again.
No.
and sir, points in
Attention of the patient to the.
That's different. There's something else. It is growing on a scar. It could well be close to being a Marjolin's ulcer, no?
Yes, sir.
Why should he develop in the first place? He has a scar there, underlying scar, and on that the ulcer has developed. So you should think in terms of Marjolin's first, which is taking it towards malignancy. Further?
And then points in examination, sir. It has everted edges, and it has induration present, which is extending beyond the margin, sir. And it is affixed to the underlying structure, which is the bone in this case, sir.
The arches are lost because of the position in which the patient is keeping his foot. Due to the trauma which he sustained, there is a deformity. The deformity led to a particular gait. He is walking on his toes. So this is an equinus deformity which he has got on the right side. So you should have said equinus deformity. That would have got you those extra marks. Right? So what will happen in equinus deformity? The arches would get
Obliterated.
Exaggerated, in fact, if you look at it this way. Like a horse, equine is horse. And regional lymph nodes,
Sir,
which are the nodes you look for? Popliteal and then inguinal, superficial inguinal group. For popliteal, put your finger in the popliteal region and hand over this to your assistant, and I can look for it. I can feel the popliteal artery very easily here, although this is not the classical position, but I can feel it. No popliteal lymph nodes. The regional lymph nodes, that is inguinal node is present, but that can be seen in barefoot walkers. And you can see, why do I say the foot hygiene is not good? There is a lot of callosities here. So it was predisposed by the trauma, for which following which there was scarring, and therefore description of scar becomes very important. Something that you've been missing out. So describe that scar at length, and the ulcer is developed on the scar. How do you proceed now quickly?
So we'll do clinical investigation to confirm the diagnosis, to support the diagnosis, to save the disease and to treat the patient. To confirm the diagnosis, I would like to get an edge biopsy, so preferably from the proliferating edge, sir, and to support the diagnosis and also as an extended clinical examination, if lymph nodes are present, we can do inguinal ultrasound to check for the draining.
Let's see, consider something locally. You need to have an X-ray, a good X-ray of the ankle joint, including the part of the foot and the proximal part. And there is a rule of 2 in X-rays, especially in the limbs. 2 sides, 2 joints, 2 views. Especially true in children. When you read about it for fractures, children have that ununited epiphysis, which can be confused with a fracture. So what do? If you do on the other side, you'll find the same thing on the other side. 2 joints, because it could be a rotation 180 degree and it is lying right there, so you may miss out the displacement. And 2 views, because you may have to see the anterior or posterior displacement. So 2 sides, 2 views, 2 joints. So X-ray is important to exclude osteomyelitis and also the good digital X-ray can show you how deep it is going. MRI, what's the CT here?
so MRI, sir.
CT, sir, because soft tissue is not.
So it is controversial. CT will show you the bones better, MRI will show you the soft tissue better. Which structure is bothering you here?
Calcaneum.
So that is more of a bone. So I would prefer to get a CT done. And then coming to the last part of it, how do you treat it?
So wide local excision.
Sir, we need to get a 3-dimensional clear margin. So if we are able to get that with a functional preservation, so if we are able to get that while preserving the bone, then it's fine. Otherwise, we might need an upper ankle amputation also.
So in this case, since it is involving the calcaneum, which is important for walking, so even if we do a functional preservation, but we have to remove the calcaneum if it is involved, then saving the rest of the foot won't help much.
The answer should be, it depends on many factors. And we usually take, if any 2 of the 3, that is joint, bone, neurovascular bundle, any 2 of them, if it is involved, then we cannot possibly preserve. So it will depend on my investigations. If the joint is fine, then I can shave off the calcaneum. I can
Yes,
get a
sir.
part of the calcaneum done. It is the intention should be to preserve. And we are removing the bone mainly because of the margin. If the margin comes out to be negative, where is the problem? And there is no issue with that. So clear margin 3-dimensionally and follow it up with adjuvant radiation if required. And if there is a node positive, based on ultrasound and FNAC, we would like to do a block dissection. Right? Now he was showing one case we just seen. I think he's got the picture of that. You can actually look at it. Where we had done a block dissection, and what is the major problem with block dissection? Sometimes the flap necrosis can happen. But this can happen with even in the best of hands. Can you see that? So we try to avoid flap necrosis, and most of the flap is otherwise fine. So this is more of an SSI,
Yes.
not a flap necrosis. So SSI should be taken care of very quickly. And now this is where you would realize we did a good thing by putting a sartorius flap.
Yes, sir.
So that the femorals are not exposed, and we can just do the debridement. So this is not flap failure. This is SSI which we need to take care of carefully. Okay, any question, Muskan? Any question, any doubt?
So, one doubt I had, sir, the dorsalis pedis actually palpate against which bony structures of
Some people say against navicular, some people say first metatarsal. Both are right. Extensor hollosis is very clearly going. The best thing is to trace it up. Make it prominent. Trace it up, and the first bone, and you feel lateral to it, that's a dorsalis pedis. Bring your finger, Muskan. You don't need a glove for that. This is the tendon, extensor hollosis.
Yes, sir.
First bone,
Yes, sir. Yes, sir.
that's dorsalis pedis. Now, so I would say against the navicular most of the time. This is it. And what Sukriti was saying, the anterior tibial, which is nothing but
extension. You continue.
this is the main vessel which is continuing down. And for posterior tibial, the point where the tendoachilles is attached to the calcaneum, medial malleolus, and the midpoint. I can feel the posterior tibial. Anterior tibial, posterior tibial, dorsalis pedis. I'm repeating, dorsalis pedis is easier to follow. If you just follow this tendon up, tendon followed, and just be careful when you reach the bone. First bone, and against that you feel right there is the dorsalis pedis, because that's where it dips. Any other doubt? Right?
Yes, sir.
Okay.